intended to qualify as or replace medical advice. Everybody's different. And I think it's really important for us to remind each other and ourselves of that. And so we always seek advice from our providers and each other in every individual case. These cases are partially real. I've changed some details just to protect privacy. I have no conflicts except that I'm an adult epilepsy specialist, so I don't see children regularly in my practice. And just be aware that we base everything we do and everything I say here on scientific evidence, but of course there's medical opinions in here that there isn't research for everything that we want to answer yet. So that's kind of exciting, but also leaves room for discussion. So what am I going to talk about today? I want to define what epilepsy syndromes are. We use this word a lot, or this two words a lot, and try to help everybody understand why it's important. I'd like to do a little bit of myth busting, and there's a lot of myths, fears, misconceptions around seizures and epilepsy, and I'd like to break through some of that, particularly with discussing the difference between what's a seizure, what's an epilepsy syndrome, and what's the cause. They're not all the same thing. And interestingly enough, you don't need to have the answer to all those questions to really get help and get treated and get on the path to recovery. And I think that's really, really important. We try to get as much information as we can, but sometimes we don't get it right away, or sometimes we don't get it at all. So, when someone goes to see their provider in, a neurology or an epilepsy clinic, these are some of the things that, although your provider may not ask you directly, this is what they're usually thinking. First question always is, are the episodes that we're concerned about seizures or not? And if they are, what kind? And we tend to focus a lot on seizures, but as I'll discuss today, we don't just focus on that. What other symptoms are you having that could be related to the seizures, or not related to the seizures, but related to everything else that's going on? Then what is the cause of the epilepsy, if that's what we're diagnosing? And then what's the best treatment plan? So sometimes we get caught as the provider or as the patient in these arrows. We say, well, we have to define the seizure types, we have to define the epilepsy syndrome, and then search for the cause, and then get to treatment. But it doesn't always have to go that way. But at least in the beginning, this is a good way to think about it, and this is a good way to help, yourself and your provider kind of work through this together. We figure out what the types of seizures you have, if there's more than one, then try to define a syndrome. And a syndrome is not the same thing as the cause, and I'll explain that. So I'm going to give two examples. This is Brittany's story. So Brittany is a 21-year-old woman who had a first-time episode with passing out, whole body shaking, tongue biting, and losing control of her bladder. This happened last week after a party at college, and this is just one episode that she had. It didn't happen before, and it hasn't happened again so far. However, she also reports muscle twitching, and this occurs upon awakening. It's been happening for the past few months. So she has no history of epilepsy in the family. She's never had a meningitis or head trauma or any other brain injury to put her at risk for seizures. She is finishing college, and she's really concerned that sleep deprivation, because she was partying, she was studying, she's worried that that's what caused her seizure. And her neurological exam is completely normal. The first myth I want to talk about here is when we talk about the cause of a seizure, people might assume it's the same as the cause of epilepsy. So that is not true. That is not true. And we really want to separate seizure and epilepsy as two related but different things. So when we talk about epilepsy, we're talking about what's the cause, the overarching or underlying cause of everything or many of the things that are going on with you. But that's different than what triggered a seizure in that moment. And there are things that can trigger seizures, and they may cause one of the seizures, but they may not cause all of the seizures. Not only that, those triggers are usually not the underlying reason for epilepsy, for the underlying condition. So here's some examples. So before I get to examples, think of a seizure as a symptom. If you start having chest pain, that's your body's way of telling you, hey, we need to check out the heart and lungs, something is wrong. A seizure is, it's very frightening and can cause a lot of physical and mental harm, but it's a symptom of something else that might be going on. It's your body telling you something is happening in the brain and we need to investigate it. So we're all searching for the cause of the symptom, but at the same time, we're trying to treat it directly, right? while we're trying to find the cause, find out if there's an epilepsy syndrome, find out what's going on, well, we want the seizures to stop, right? So there's many different kinds of seizures, and that's the first place to start when you're getting evaluated or your doctor is kind of working through this with you. So I like to break them up, and I say I like to break them up, but I should say that the official guidelines from the International League Against Epilepsy, the American Epilepsy Society, the large foundations, including the Epilepsy Foundation, they all agree that for the most part, this is the best way to break up seizures. I've simplified it a little bit. There's more different types, particularly in pediatrics than other schools of thought. But in general, focal seizures and generalized seizures. Focal meaning one part of the brain, generalized meaning maybe the whole brain, not necessarily the whole brain, but a lot of both sides of the brain, a large part of the brain at once. So, and there's two types of focal seizures, focal aware and focal impaired awareness. The old terms used to be simple partial and complex partial, but generalized seizures, we're all aware of generalized tonic-clonic. It's what we used to call grand mal, those violent shaking seizures, fall to the ground, tongue biting, losing bladder control. That's kind of what you see on TV. But as you work through it, with patients and providers and together, we kind of realize there's all these other types. So we have to all work together to figure out all the different types of seizures that a patient might have. And some patients have only one type, some patients have multiple. So once we figure that out, then we're thinking bigger, beyond just the seizures, to figure out, is there an epilepsy syndrome? So again, let me differentiate seizures from epilepsy. Seizures can have triggers, and they don't always have triggers. Sometimes they just happen without any obvious trigger. But these triggers can cause a single seizure, but they're not the underlying cause. What I mean is, if you remove some of these triggers, you may stop some seizures, but not all. So I've drawn a line here. Why have I done that? The top four things: stress, emotion, missing the seizure medication, sleep deprivation, fever or illness, sickness. These usually trigger seizures in patients with epilepsy. Somebody who doesn't have epilepsy shouldn't have a seizure from this problem. I mean, pretty much everybody's doctors have survived residency with horrible sleep deprivation and being up for so many hours at a time. And that doesn't trigger seizures in most of these people. Many of us have experienced severe emotional or physical stress throughout our lives. Many of us have had flu or pneumonia or even COVID, heaven forbid. But by and large, those patients do not develop seizures because they don't have epilepsy. So separate from seizures, if you have epilepsy, these things can trigger seizures. Now, the bottom four things on the list: medication, certain medications, alcohol or drug use, electrolyte and blood sugar abnormalities, these can trigger seizures in anybody. If your blood sugar drops to 0, anybody could have a seizure. If there's excessive alcohol or alcohol withdrawal, anybody could have a seizure. They aren't the whole story. They aren't the cause. Removing them may not stop all the seizures. And that's where finding an epilepsy syndrome, finding the cause, considering seizure medication as a treatment is very important. So epilepsy, I like to think of it as an ongoing risk, meaning even if we got rid of all those triggers, somebody's still at risk for seizures. We use the term seizure disorder. That really means the same thing as epilepsy. But epilepsy isn't just seizures. There's a lot of other factors here. And as far as causes, it could be due to an injury, genetics, immune system problems, or infections, structural problems in the brain. There's a lot of different causes. So most of the time, the cause is unknown. And I know that's scary, but that's okay. We still have fantastic treatment options that once we can dig into the problem, we can offer. And there's some cases in which not knowing the cause is actually a good thing. I'm going to go over that now. So going back to Brittany. So, we talked about her first time episode, which really sounds like a generalized tonic-clonic seizure. So that's what I have as number 1 here. She has 2 seizure types: generalized tonic-clonic seizure. And the second seizure type is myoclonic seizures. These are brief muscle twitches that occur upon awakening. Now, okay, not everybody who twitches when they wake up has myoclonic seizures. We've all had twitching when we fall asleep or wake up. It's confusing. That's also called myoclonus, but that's benign myoclonus. That's not seizures. We all have that when we're tired or whatnot. But in Brittany's case, they're myoclonic seizures. And the reason I know why they're myoclonic seizures is because of everything else I'm about to talk about. It's her EEG and everything. Okay. So she's really worried about the sleep deprivation so was I when I saw her. I'm worried it could trigger another one, but we both wanted to understand beyond the sleep deprivation, why is she having this problem? So we did a brain MRI. It was normal. We did an EEG and it shows this abnormal pattern, which I won't discuss in much detail, but it's a very specific pattern that really helped us figure out what's going on. And it's quite common in seizures starting in this age group. So let me go back to this. So we've got through the seizure types, and I've done an MRI and EEG, and now we're going towards figuring out and defining an epilepsy syndrome. So we diagnosed her with juvenile myoclonic epilepsy, JME. She started on lamotrigine. That is the syndrome that she has, and in this case, genetic testing is not necessary, and I'll explain that. So unfortunately, we had to restrict her from driving for 6 months, and she worked with her roommates, her friends, and family. She avoided all-nighters, avoided alcohol, and thankfully, seizures did not recur. She graduated college, she starts her first job, and she got married. So what is a syndrome? When I said she has juvenile myoclonic epilepsy, I think the best way to define a syndrome is really a group of things that occurs together a lot. It's puzzle pieces that fit together. We see them together so often that it means something important. So what are these things that we see together more often? Seizure types. What age the seizure started at, that's really, really important, actually, really important. The age at which the seizures start is not necessarily the age at which the first seizure was recognized by the patient, by families, by the doctors. So it really can be helpful when you go to your doctor and say, hey, you know what? I know I had this big violent shaking seizure and that's when everybody got worried about it. But if I look back 5 years, some other strange things happened and we should talk about that. Age is very important. And then parts of the brain involved. And that has to do with the symptoms of each seizure and the EEG, and we'll get to that. Why is this important? And this is probably the most important reason that we want to figure out if somebody has an epilepsy syndrome is prognosis. Many of these cases, once you know the syndrome, you can help the patient understand what's going to happen in the future and what treatment options are best for them. And that's fantastic. Sometimes there's genetic information. So think of all these things as puzzle pieces. You have to put all these eggs together into the correct basket, the correct syndrome. So I've taken the same information we talked about and put it in a different way. So these are all my puzzle pieces. The types of the seizures, the age, pattern of seizures when they occur, meaning time of day. If the patient has other problems in addition to seizures, what shows up on the EEG, what shows up on the MRI scans, what parts of the brain is involved. And then if there's genetic information, family history, if the seizures are inherited. You can take all those pieces, sometimes you don't have all those pieces, as many as you can, put them together and come up with a specific syndrome. Now, I want to make a very important point that you cannot always do this. And actually, in most cases, you cannot necessarily do this, come up with a specific syndrome. That's okay, all right? That's okay. We still have a good way to treat based on a lot of other pieces of information. So, but hopefully if you can find a syndrome, you can provide even more information. Prognosis, whether there's going to be recovery, what treatment options, are you going to get worse in the future? It helps us figure out the future. So let's put this to work for Brittany. Oh, before I get to that, I just want to point out there's so many different epilepsy syndromes. This list is, this is not even a complete list. There's a lot of different things out there. And we don't have time to discuss them all, obviously, but many patients don't fit into these categories very easily. And again, that is okay. We still have a good way to treat a majority of patients, nearly all patients with seizures and epilepsy. But I wanted to highlight a couple of these. We're already talking about juvenile myoclonic epilepsy, and then I'll do another case where we talk about a different syndrome. So let's put these puzzle pieces to work for Brittany. So the first one on the left, types of seizures. So she has generalized tonic-clonic seizures, myoclonic seizures, starting in her teenage years, triggered by alcohol and sleep deprivation. She had a normal brain MRI. She had a specific EEG pattern. She has what we call generalized epilepsy. Generalized meaning all of her seizures, the myoclonic seizures and the generalized tonic-clonic seizures, come from most of the brain, or you could say almost the whole brain at once. I do want to make the point that just because the seizures come from the whole brain at once, and just because they're generalized and look violent symptom-wise, that doesn't make them more dangerous in the long term. Now, yes, having a generalized tonic-clonic seizure, that's probably one of the most severe types of seizures in terms of physical injury. It's dangerous, right? You don't want to have one where you fall down with violent shaking and so forth. But just because the seizures are like that, coming from the whole brain at once, doesn't mean it's going to be neurologically dangerous as long as we get them under control. So I guess what I'm trying to say here is you can figure out the seizure types, but you can also figure out the syndrome separately. And you can go ahead and treat her, which we did. And once we figure out the long-term issues, we can help plan out for the future. So she had a normal neurological exam, and she did not have any family history. So we diagnosed her with JME, juvenile myoclonic epilepsy. Now, what is this? So it's really what I just said. Seizures start relatively early. As an adult doctor, I think this is early, right? I see 80-year-olds too, but they start in the teens or early 20s. Patients have to have myoclonic seizures, usually have generalized tonic-clonic seizures, may have absence seizures. Patients usually do not have any developmental or intellectual problems. The brain MRI should be normal, and the EEG is the most important way to diagnose it. Now, this is a bit tricky, right? This is really confusing. Even when I was doing my epilepsy training, this confused me for a long time because it's complicated. The official classification for juvenile myoclonic epilepsy is a genetic epilepsy. It's called genetic. However, it's a bit of an oxymoron. There is no gene that you can test for easily. There is more often than not, about half the cases, no family history. And often it's not passed down at all. So why do we call it genetic? I don't want to get into the technicalities of that. It's kind of complicated, but the point is, this is really common as a cause of epilepsy. Recognizing this syndrome helped her a lot because we got her on the right treatment, and I could confidently tell her that there's a 90% chance we're going to stop your seizures. You can go on to have a normal and healthy life, and she has. And the other key point with this is most of these patients do need lifelong treatment. Even if seizures stop for 10, 20 years, usually we don't stop the medication. And that's an important counseling piece of information. So continuing her story, a few years later, she's planning to become pregnant. So she does go see the high-risk obstetrics OB clinic because she has a history of epilepsy. She started on folic acid. She eventually does become pregnant. We continued lamotrigine, and we had to adjust the dose during and after pregnancy, but everything went well. She had no seizures during pregnancy. She delivered a healthy baby boy 9 months later. And, this is, I don't know this part yet, admittedly. This next piece of information is I combined from a different patient, but I've had several patients with JME, juvenile myoclonic epilepsy, who've gone on to have normal, healthy children, and those kids grow up, they do not have seizures. This is not a condition in which it's guaranteed to be passed on just because we call it genetic, okay? So that's the myths I want to bust with this first case. Just because we don't know the cause of JME, we don't, does not mean it's hopeless. There is a lot of hope for patients like Brittany. Just because it's genetic does not mean it's inherited and does not mean you're going to pass it on, okay? You can, but it's important to work with your neurologist, your epilepsy specialist, genetic counselor if necessary, to work through everything together. The other important thing, this is probably the most important thing, do I need to know the reason for my seizures to decide treatment? No, you don't. Actually, we talk about all these syndromes and genetics, and by and large, most of the seizure medicines we have available to us today in 2021, there's about 30 of them. Most of these seizure medications, we most often don't know the cause of the seizures, and we decide treatment, and about a majority, more than 2/3 of patients, were able to stop the seizures completely. Okay? So I don't want these myths to hold us back. Let me switch gears. I'll take the last 10 minutes here or so and talk about Emily's story. So Emily is a bit different than Brittany. She is 19 years old. She's had seizures since birth. She has multiple seizure types. So she has violent whole body shaking episodes. She has episodes where she suddenly loses muscle tone. So she will drop or fall down without warning. And it lasts a second or two, and then she's awake and she's okay. Okay mentally, but of course she can have physical injury. And unfortunately, she does have physical injury very frequently. She also has staring episodes with confusion. So, I think this is a good follow-up point to Dr. Millichap's excellent talk last month. Of course, I didn't take care of this patient since birth. She was transitioned to me from a pediatric epilepsy clinic, and where she was taken care of very fantastically. But whenever I see a patient new, I kind of want to start over and provide as much opinion as I can to help think of it from a new angle. So she does have associated intellectual disability. She functions at about a 2-year-old level. She attends a day program, physical therapy and speech therapy. But lately, the physical therapy and speech therapy have not been helping as much. So let's go back to how we think through this, right? We define the seizure types, we try to figure out if there's an epilepsy syndrome, and we search for a cause. For Brittany, we kind of stopped searching for a cause because we knew it was juvenile myoclonic epilepsy and that genetic testing was not going to be helpful. This is going to be a bit different. So we think in our minds that, oh, well, we need to know the cause to find the best treatments. But fortunately, we don't. If we know the syndrome, you could find the best treatments. And in many cases, even if you don't know the syndrome or the cause, you can still find the best treatments just based on the seizure types. So let's define her seizure types. She has generalized tonic-clonic seizures. Number 2 is what we call atonic, loss of tone. That's what atonic means. Muscle tone is suddenly lost and she falls down. Atonic seizures. And staring episodes, well, those might be absence or focal seizures. We'd have to dig a little deeper to figure that out. But we can be successful in treatment by knowing her seizure types. And of course, this is not the whole story with her. So we've already talked about this in some detail. Controlling seizures is the only thing that is needed to get better. Well, the doctors who had been taking care of her before me had done a fantastic job, as best as possible, to control as many seizures as possible. But despite their best efforts, she still has seizures. But not only does she have seizures, she has intellectual, speech, walking problems, and we need to be able to help her with that. Now she's getting physical therapy, she goes to a program, she's getting help, but I think we have to remember, and I feel like as the physician, I have to be reminded by my patients sometimes, and I try to remind them that controlling seizures is not the only thing we need to get better. And that's because epilepsy isn't just seizures. Epilepsy has biological, cognitive, psychological, and social consequences and problems, challenges associated with them. And we try to help with all of these things. And that's, I think the Epilepsy Foundation, particularly in Chicago, can really help advocate for a lot of these things that admittedly I can't solve in the patient's room. I'm sorry, in the office with the patient, because we need to work all together to solve a lot of these other issues and support our patients and their families, because the caregivers need support too. And this, related to this, is what we try to work on in the office. Remembering that seizures are not the only symptom of epilepsy, and it can include other organs. So even though seizures are not only this, even though seizures are not the only symptom, it doesn't just mean that the brain is everything, right? We have to remember that epilepsy doesn't just affect the brain. It can affect a lot of other organ systems depending on the cause. So, as I reviewed her records, she'd already been diagnosed with this. Her EEGs had shown what we call slow spike and wave discharges and multifocal sharp waves, abnormalities in the whole brain, but also in multiple parts of the brain. The MRI brain in the brain MRI in the past had shown multiple tubers and subependymal nodules. These are specific lesions, which I'll discuss in a bit. And she had been diagnosed with Lennox-Gastaut syndrome. So rufinamide had been added, in her teenage years, and it did decrease her drop attacks, and she was wearing a helmet. So she still has seizures and she wears her helmet, but thankfully with this medication, she no longer falls suddenly and she's no longer having injuries. So that was great. That between the pediatric doctor and myself, we kind of started this, we worked together and we helped her. But again, this is not the whole story. We found a syndrome. We figured out the medicine to help with a specific seizure type. But what is Lennox-Gastaut syndrome? So it is, in my mind, a bit the opposite of juvenile myoclonic epilepsy. It's a severe form of childhood epilepsy where patients have multiple seizure types, and it can persist. Despite treatment, it can persist through the years, adulthood even. And these are patients who often have intellectual impairments. Now, this is a bit tricky. This syndrome, in many cases, you don't find a cause, but this syndrome has many causes. Let me explain that. So when we take a lot of patients who have Lennox-Gastaut syndrome, we do assess for genetic abnormalities, metabolic disorders, other causes. And in many cases, we find causes. So there are many different genetic and metabolic and structural diseases, conditions that can present like Lennox-Gastaut syndrome. So like I was saying before, a syndrome is a bunch of things that occur together a lot. And bunch of things meaning seizure types, intellectual problems, yes or no, certain age of onset, certain MRI and EEG findings, they occur together a lot. So I can figure out that syndrome and use that information to start good treatment. But in this case, that's still not the whole story. And we have a lot of different treatment options. At the bottom, I talk about seizure medicines, diets, implanted devices, surgeries. And we can offer many of these options to patients like Emily. But, we talked about syndromes. We have to think beyond that. So let's put these puzzle pieces to work for Emily, all right? So I've shown you this before, and let's put these puzzle pieces. So, sorry, the chat was messed with my screen, apologies. So she has several different seizure types: generalized tonic-clonic, atonic, and absence. Seizures started shortly after birth, and she's falling down quite frequently until we started rufinamide. Her EEG showed a distinctive pattern, and MRI showed specific abnormalities. She has multiple brain areas involved that are causing seizures, but not only causing seizures, causing her other problems too, right? Causing her intellectual impairments, her speech and walking difficulties. So we figured out she has Lennox-Gastaut syndrome. But this bottom right corner, I haven't addressed that part of the story yet. So before we get to causes, syndromes I think are really important because it gives us a way to communicate with each other. We can use a certain word like Lennox-Gastaut or juvenile myoclonic and know what each other mean to some degree. It can help us plan for the future, and we can do diagnostic testing, and we can treat her without knowing the cause. But the hard part is, like I mentioned, with Lennox-Gastaut syndrome, there are so many causes, and there is not a simple way to test for all causes. I mean, it's not just cost, but it's impractical. When we send a blood test, we can only test for the one or two things I'm thinking of, right? There's a lot of very exciting advances in technology and genetic testing where you can test for 100 or even 1,000 different or 1,000,000 different disorders with a few simple vials of blood. But even testing for 1,000,000 things, well, we have billions with a B of genetic material in our DNA, right? And there's a lot of things we could find, but we don't know what they mean. So it's very difficult. So we can't test for everything. But in this case, in Emily's case, we dug a little deeper. And the pediatric neurologists, they're fantastic. They figured this out many years before she came to me. So as I was reviewing all this, found out that her mother had a similar but milder condition. And she has a lot of non-seizure symptoms as well. Acne, well, what was called acne, but it turns out not to be. Patches on her skin. She was actually found to have a kidney tumor several years ago. It was removed. And though we improved her seizures, as I mentioned, her speech and walking had not. So we sent them to a genetic counselor, and we suspected tuberous sclerosis complex. The testing was ordered for this disease specifically. So there were some pieces of the puzzle that I've marked in red that I've added here that helped us go beyond just a syndrome and find the cause. Okay? And that helped us figure out not only the prognosis, but treatment. So briefly, what is tuberous sclerosis complex? It is an autosomal dominant disorder. That means that it's passed down directly, and when you pass it down from one, it can be passed down just from one side of the family. You don't need both sides to have it to pass it down. it means that there's a 50% chance of passing it down. But the strange thing about this condition and many genetic conditions is they can be spontaneous. We talk about genetics meaning inherited, that you get everything from your mom and dad. That's not entirely true. It's strange to say this, but we're all mutating. Not necessarily in a bad way always, but it's not like the X-Men, but we're mutating, right? As a baby is conceived, 9 months in the womb that those cells are dividing and the genes are developing. So people are mutating and evolving through those 9 months. And even as we get older, our genetic material and DNA changes. Unfortunately, sometimes in a not a good way, and it creates cancer and things like that. But I just want to make the point that, again, just because we say genetic doesn't mean you're going to pass it down for sure. Doesn't mean your parents had to have had it. We find these things spontaneously. So almost all of these patients have seizures, and many of them become difficult to control. And many of these patients have other systems involved. This is very, very important, not just for long-term treatment, because you have to check the other organ systems to make sure they're not affected. And the most exciting piece in tuberous sclerosis is there are treatments such as everolimus specifically designed to affect the genetic problems. And they don't just treat the seizures, they treat the other parts of the diseases too. Okay? So she can have this diagnosis confirmed. We had to do heart testing. Thankfully, no heart tumors were found. We did lung testing. We did find this thing called lymphangiomatosis, which can cause breathing problems and things down the line. So she had good follow-up with her lung doctors, her kidney doctors, her epilepsy doctors, and we watched her over the years. And as that time went on, we started everolimus. It had been offered to her when she was younger, but it was brand new, and the mom wanted to wait a little bit. So by the time she came to me, we started this. And this helped with her other symptoms. She walked more steadily, she spoke more words, she smiled and became more interactive. It was really good for her quality of life, and her and mom were just happier. And I think that's really fantastic for her. It's exciting that we have these kind of treatments. So, I hope I've kind of summarized two different types of syndromes here. Not all epilepsy conditions fit into a syndrome, but it is important to look for it. Some syndromes don't have causes, but some have multiple causes. Tuberous sclerosis is one cause of Lennox-Gastaut. There's so many other causes. Knowing the syndrome, knowing its cause, can change a treatment plan or offer information about the future. And I think that's really important. So I just want to list some resources at the end here. I think these websites are all fantastic. I'll just make a point that the Epilepsy Foundation has similar information as the International League Against Epilepsy. If you look at this epilepsy.com/learn, and then you look at epilepsydiagnosis.org, it's actually very similar information. I just think the epilepsydiagnosis.org is a bit more technical. So I'll stop there, and thank you very much, and I'll open up for discussion.
Awesome. Thank you, Dr. Bhatt. That was really interesting. I was just saying before you came on that I personally have a lot to learn in the space of syndromes. And as you alluded to multiple times, that us kind of learning more about the syndromes is definitely a quicker road to treatment and just improving quality of life. So what about for people? So is this also the new way of giving a diagnosis, is to try to get to a syndrome quicker? Is that kind of the plan?
I think so. I think it's a long road ahead because there's still a lot we don't know. And I think that scares patients and families, but I think it scares us too, because we think that we feel like we have to know everything before we can help people get better. And I think that we don't. I think we are doing everything in parallel, figuring out treatments, figuring out syndromes, figuring out genetics and causes. And I think it all has to occur in parallel. We can't wait. But I think the science is moving fast enough that everything is happening.
So I like what you said. And so does that mean that someone who maybe has been diagnosed maybe like 7-10 years ago, is it worth them to kind of revisit this conversation and see if they can get more information and get a more tighter diagnosis?
Yeah, I think so. I'm always a big fan of getting more opinions. We work together with all the epilepsy faculty at Rush, at all the other local fantastic epilepsy centers we have in Chicago, nationally. We're always sharing ideas, and I'm always glad to rediscuss with my patients, and I'm always glad to offer them to see someone else to get another opinion. We all work together, and it's good to get a fresh pair of eyes and brain, no pun intended, on anybody's situation.
Very true. Yeah. And thank you for giving the plug to the Epilepsy Foundation. We definitely have caregiver groups, and we're really excited now that we also have the clinical side of things. So as you mentioned, epilepsy is a multidisciplinary situation where we want to make sure we address all the aspects of the whole human. So we're really excited that we can offer these services as well in conjunction with all the great work that you're doing.
So I'll go ahead and ask a question, Dr. Bhatt. Kimberly Jansen, Epilepsy Foundation, and my colleague with Alex and Aisha. Nice to meet you. Thanks for tonight. So recognizing the tuberous sclerosis, I don't know if I caught what is the percentage, of the likelihood of this tuberous sclerosis. Does that make sense?
Yeah, meaning how often do we find it? How often is it?
I mean, I recognize that it's relatively rare, that I do know, but I'm wondering, with all the research that's coming forward and, like you said, all the advancement in treatment, are you definitely finding more of these difficult syndromes like Lennox-Gastaut, Dravet, etc., more common?
I think it's hard to know whether they're more common or we're just getting better at finding it, It's hard to say. I agree with you. A lot of this stuff is rare, and sometimes we hold out hope that we want to have something rare because it has a special treatment like this, and sometimes we hold out hope that we don't want to be the rare. I'm always sitting here thinking, you don't want to be the one in the doctor's office where they say, that's interesting, right? I mean,
right.
I think, it's the silver lining of 2020 and 2020 and 21. I think virtually we've been able to bring a lot of people together and have these conversations and bring patients and families together and get second and third opinions and get people to the subspecialist or to some expert to figure something out that, we're all practicing neurology and epilepsy and taking care of patients within the best of our ability. And sometimes we need that connection and help to find these rare things.
Right.
I think, it's hard because some of these things are rare, but it doesn't mean we don't stop looking.
Right. It's kind of interesting, because I didn't know what you were going to speak of tonight, although I did know you were going to speak about adult epilepsies. And I just recently had someone reach out about more childhood, if you will, but tuberous sclerosis. So it was just, the irony of it all. And they were in Georgia. So.
Yeah. Tuberous sclerosis, I'm not an expert on it, certainly. I'm sure the pediatric epileptologists see it more than I do.
No, but it was interesting.
But I think tuberous sclerosis, it's a wide spectrum. We think of it as one, there's not one condition called tuberous sclerosis. It presents so differently in so many people. Some people have very severe seizures. Some people have mild seizures. Some people have different levels of intellectual problems. Some people have more kidney and more skin or more. It affects everybody so differently that we ought to think of these things more commonly, because you might be surprised where you find them and where we can help,
Thank you. Thank you very much.
I have a question about EEG as a diagnostic tool. A number of my daughter's seizures have not shown up on EEGs in the past. She has tonic and infantile spasms most of the time. She goes through a variety of different types. And I've heard from other families of their children's EEGs also not showing abnormalities during seizure or not picking them up. And and as far as what's happened with us is we've always, yeah, baby, the neurologists we've worked with have always, said, let's, take the videos into account. Let's try this, let's try that. But I know, babe, I'll be there. Sorry, that's why I was on mute. Kids. But I've heard of some other families where their neurologist will just say, this is not seizure activity, what you're seeing, and you need to come up with other solutions, or I don't know, just it seems like if it's not on an EEG, parents feel like they're not being believed sometimes, which is really hard because you know what you're seeing, and when your child's having seizures every day, you know what seizure activity looks like. So how do you feel about EEG as the tool?
I feel for you. I feel like it's very hard. I'll tell you just a side note. When I'm teaching, the students and the trainees and everything, more often than not, you'll hear me say something like, "This is the epileptologist telling you that don't order the EEG. It's not the be all end all." I wish we had such a definitive test that could answer all these questions for us. And maybe with technology in the future, we will. Right now, EEG does have limitations, It's hard because there are things we know are seizures that don't show up on EEG, and there are things we know aren't seizures that do show up on EEG. It's not a perfect test. And sometimes sometimes we are limited by our tests. And I think that's when we really have to, I took one slide out here. I should have left it in. It said, the tests are more important than my story, right? I just ran out of time, didn't have a chance to talk about it, but I'm glad you brought it up. I think this is when your healthcare team, the caregivers, the families, we all have to come together and not rely just on the tests. We use your story, home videos in the hospital that we've taken when you're hooked up to the tests. We use everything else to give you the best care and best treatment options that we can, That's the way I like to think about it. It's just like epilepsy isn't just seizures. EEG isn't the only test,
Mm. Yeah, definitely. Yeah, I think so. And in our case, her infantile spasms weren't diagnosed for like 3 months because she had multiple EEGs and there was no hypsarrhythmia. So that was upsetting, but understandable. Like when you expect to see something and it's not there, then, you hear hoofbeats and you don't think a zebra. So yeah, that your summary is kind of in a roundabout way the way that our team went. I think it took a little bit longer than I would have liked it to, but yeah, that is reassuring to know that neurology and epidemiology students are being trained that it's not 100%, that tests are not 100%.
I'll share with you what one of my mentors taught me. It's been almost 10 years now, but I tell everybody, epilepsy is a humbling practice. We do these tests and we keep following patients over time, even if we think we know what's going on, because many times we're not correct the first time around, and that's okay. Our job is not to get the right answer. Our job is to take care of you, and we hope that both happen right away, but it doesn't always. I understand.
Thank you.
Victoria, I had a similar thing happen in that my daughter has epilepsy and has a variety of seizure types, and we're at Rush with Dr. Smith and Debbie Zielinski. And I was recently last year with my father, who had an accident. He fell off the roof and was life flighted to a trauma hospital. And in the course of his care, he started having what looked like seizures to me. And I brought the nurse in and I said, I think he's having myoclonic seizures. And they looked and they were watching him and they really didn't think so. And so I started, videotaping it. And another person came in and they didn't really think so. And then by the next day, his levels had gotten so bad in his body, he was in the emergency room. The emergency room nurse looked at me and she said, he's having seizures. And I said, yes. So it's really, it's hard sometimes. And it is sometimes, things look different. So I think that the puzzle pieces, I really appreciate you talking about that, Dr. Bhatt, because I think that there's a lot of puzzle pieces that need to be fit together. And sometimes things do look one way and they can be the other. And so for parents and for doctors alike, I think that's a great thing to talk about, are the puzzle pieces. So thank you.
You're welcome.
Thank you so much for your time. This is a wonderful presentation. And again, this will live on our YouTube page. So if anyone wants to go back and take a look at it, it'll be there. So again, thank you so much for your time. And I wish everyone a great evening. And your contact info, people can get a hold of you through Rush, so they can find you on your website.
Definitely.
Great.
All right. Thank you, everybody.
Thank you.
Stay
Good
safe.
night.